Good morning. Welcome to another edition of the Department of Medicine's Grand Rounds. Thank you once again, everyone who's come in person. We really appreciate it. I'm sorry about the food issues. We usually do have really great kolaches and coffee, and they'll be back next week, double the force. So come back to make up for this week's. Today, though, we do have a 2-for-1 special with cardiology and oncology presenting about amyloidosis, kind of complementing from our talk 2 weeks back. But we have Dr. Joshua Mitchell and Keith Stockerl-Goldstein. So they're going to give us perspectives from both sides. So without further ado, Dr. Stockerl-Goldstein.
All right, thank you, Dr. Celsius. Thank everyone for showing up even without kolaches. That was the whole reason I was actually coming. So what Dr. Mitchell and I are going to try and cover is some diagnostic obstacles. What are some of the barriers to making this diagnosis of amyloidosis? And then some of the treatment advances that have happened in the past few years. This is a topic my fellows can tell you I could talk for 5 hours nonstop about amyloid. So I'm going to try and be brief and just cover some essential things. And I'm hoping some or all of you were at the Grand Rounds talk 2 weeks ago by Dr. Lee and Dr. Vidge, because Dr. Vidge covered some of the things about amyloid, so I won't repeat some of those. These are my disclosures. So what I want to cover in my part of the talk is, again, what are the barriers to diagnosis? Why is this such a difficult diagnosis to make? And why are there so many delays? Then we'll talk about briefly the workup of light chain amyloidosis, and I'm going to focus on light chain predominantly. And Dr. Mitchell will be talking mostly about TTR and cardiomyopathies. And then we'll talk about the treatment of amyloidosis, our current treatment paradigm, and how we take some of the newly approved agents and use them along with stem cell transplant and some investigational agents as well. So just a primer on amyloid, if you don't remember it. So amyloid or amyloidosis refers to the deposition of fibrils in the extracellular matrix. These fibrils are made up of small protein subunits that typically misfold and then start to form beta pleated sheets, and then aggregate with some other substances such as serum amyloid protein and glycosaminoglycans, and form these amyloid fibrils that are sort of disorganized. They deposit in various tissues. And interesting, at least with the light chains that are coming from clonal plasma cells, the light chains that are amyloidogenic actually in vitro have direct toxicity to some cells. So even before they form fibrils, the amyloidogenic light chains circulating in the blood actually have direct toxicity to the cardiac myocytes, for example. And we don't know a lot about the reasons that some light chains form amyloid and some don't. But the driver for this in the light chain amyloid is almost always a clonal plasma cell process. So you heard a bit 2 weeks ago about monoclonal glomerulopathies of clinical significance or renal significance, and amyloidosis is one of those that we list in there. So what are the barriers? Why is it so difficult to get a diagnosis? And I think the first thing is that the symptoms of amyloidosis are very nonspecific. And going back to my days in my internal medicine clinic as a resident, these are the most common complaints of someone with amyloid, and pretty much the things I would hear in my internal medicine clinic: lethargy, fatigue, shortness of breath, edema and weight loss, symptoms of congestive heart failure, diarrhea or constipation, peripheral neuropathy, and dizziness with standing. And so things that don't necessarily get you into a differential very quickly of amyloidosis. And because of these pretty nonspecific symptoms and difficulty in making a diagnosis and assessing these, it turns out that multiple providers and specialists are involved in making the diagnosis and finally getting to that diagnosis. And this is a study that was done, an online survey of over 500 patients with amyloid, their caregivers, and significant others. And this shows that over 2/3 of patients saw 3 or more physicians before they made a diagnosis of amyloidosis. And almost 1/3 of patients had to see 5 or more providers from the time of symptom onset until the diagnosis. So that, as you know, each provider takes some time. I won't go through this in detail, but you can see the first visit in blue. Almost all of the first visits are with their primary care provider, coming with, again, these nonspecific complaints and trying to make sense of them. But many other specialists are involved. Hematologists, oncologists, cardiologists, nephrologists are the most common But some of these patients are seen by endocrinologists because they can present with endocrine disorders, gastroenterologists because of GI involvement or liver involvement, even orthopedic surgeons, because some of these patients will have as a symptom of their amyloidosis, carpal tunnel syndrome or spinal stenosis. And specifically in light chain amyloid, you can see that the organs that are involved are pretty varied. Cardiac involvement is seen in about 80% and renal involvement in 65% or so, but also significant involvement in the soft tissues, including the GI tract, the peripheral and autonomic nervous system, and the liver. I'll show you a slide that's very detailed, hard to read, about what our workup is for a patient with light chain amyloidosis. It's fairly complicated, and it's hard to know, is this a patient that should start getting that workup, and how invasive should you be? And the disease amyloidosis is considered rare, but then the question is, well, what exactly is rare? The estimate now for light chain amyloid, so just AL amyloid, is 5,000 to 7,000 new cases a year. That's roughly the same as number of cases of Hodgkin's disease, for example, that are diagnosed. And we know that this is definitely underdiagnosed. The median age is 64 and increases with age. Each decade, we see a higher prevalence of this. But all of these things lead to significant delays in diagnosis and treatment, and that has an implication in how sick the patients are when they get to us. So this is that same survey, again, over 500 patients and caregivers, looking at the time it took from their initial symptoms to making a diagnosis of amyloidosis. And you can see that over 1/3 of patients took one or more years, and about 20% of patients that took 2 or 3 or more years to actually make a diagnosis. And this is another way of looking at it. This was an analysis of an Optum healthcare database where they analyzed over 1,300 patients who had a documented diagnosis of AL amyloid, and then they searched the database for terms that would be part of the signs and symptoms of amyloidosis. So things like fatigue, shortness of breath, arrhythmias, nephrotic syndrome, and so on. And they found in this that it was a median of 2.5 years from the time a first symptom or sign showed up in the patient's electronic health record until a diagnosis of AL amyloid was made. The patients that had the quickest time from symptom to actual diagnosis were the patients with nephrotic syndrome. And that goes along with what you heard 2 weeks ago about, the rapidity of needing to do kidney biopsies in patients who present with nephrotic proteinuria, whether it's from light chain amyloidosis, other MGRS, or other etiologies. And in this study, over 90% of patients visited 5 or more provider types between the time they first started having symptoms and making the diagnosis. And discouraging for me and my colleagues is that 25% of these patients had a monoclonal gammopathy detected a median of 1 year prior to AL. And we know that this is one of the diseases that monoclonal gammopathies can turn into. Multiple myeloma is the thing we most typically think of, but amyloidosis is definitely is on the radar. Dr. Mitch is going to talk a lot more detail with a lot more data about, how do you screen patients and start saying, well, maybe I should think about amyloidosis. I assume everybody has amyloid that I meet until I rule it out. Certainly patients who you see in the clinic or you see on the inpatient units who have infiltrative or restrictive cardiomyopathies, but patients who have autonomic dysfunction, orthostatic vital signs, obviously patients with proteinuria need to be evaluated, and amyloid should be part of that workup. Patients who have really new onset, rapidly progressive peripheral neuropathy. Again, the age group that we're dealing with in their upper 60s have other comorbidities, and we see many people who come with that diagnosis of diabetic peripheral neuropathy, sort of nebulous. But someone who's had diabetic peripheral neuropathy for 5 years, but says, in the last 6 months, it's gotten to the point where I can't sleep at night, I can't walk because my feet hurt, is not what you'd see with diabetes. Something else is going on. Dr. Mitchell will show you some details about some carpal tunnel surgery data, but we know in one study of patients who have spinal stenosis surgery, if you actually look for amyloid, about 10% of those patients have amyloid deposits in that tissue if it's looked for predominantly of the TTR type. And very high on the list should be any patient who has a monoclonal gammopathy, whether that's multiple myeloma or monoclonal gammopathy of undetermined significance. We know these patients have clonal proteins floating in their blood, and we do know that this can turn into amyloidosis. There's a really large exciting study going on in Iceland to kind of help us with determining what is the natural history of MGUS. And Dr. Vidge, I think, showed a slide from it. But in Iceland, they voluntarily got just over 50% of all of the adults over age 40 to give specimens and enroll in a study to follow the natural history of MGUS over time with either routine observation or very detailed testing. And so they're giving data every year about how many patients eventually turn into amyloidosis or multiple myeloma, and can you actually detect this or prevent that from happening? The criteria when we see a patient, what do we need to do to say, yes, you have light chain amyloidosis and we need to put you on therapy? The International Myeloma Working Group has 4 criteria. One is the patient has a presence of an amyloid-related systemic syndrome, so cardiomyopathy or nephrotic syndrome, autonomic dysfunction. We have to confirm that they actually have amyloid, so that means getting a biopsy and doing Congo red staining. Congo red staining is able to tell us there's amyloid deposit in the tissues, but all amyloid under the microscope or under EM looks the same. You can't tell the difference between light chain or TTR. Insulin can cause a type of amyloid. Recently, there's now 42 types of amyloid described. Anakinra can actually cause amyloid as well. It's just been added. So we need to confirm that the amyloid is light chain related, and that's done with some various techniques I'll talk about. And then also that the patient has a monoclonal plasma cell proliferative disorder, meaning we need to find some evidence of a clonal protein in their blood, which would be a positive serum or urine paraprotein, an abnormal free light chain ratio, or clonal plasma cells in the bone marrow. So here's that complicated workup that I mentioned. These are all the things that we start doing for our patients who show up, refer to us for a possible diagnosis of amyloidosis, and you can see it gets fairly complicated. The basis of it is what we do for anyone with multiple myeloma, which is look for serum paraprotein. So serum protein immunofixation and electrophoresis, 24-hour urine collections for total protein and immunofixation, because sometimes the proteins show up only in the urine and it's such a low concentration that a urinalysis, a spot urine, is not going to give you any useful information. And then serum-free light chain tests, looking for those fragments of the light chains from the immunoglobulin that are floating free. We do a bone marrow biopsy in all of these patients because we're looking for those clonal plasma cells, but we also stain with Congo red, looking for amyloid deposition. And it's very important to have pathologists that actually know how to read those Congo red stains. So that what they look for under polarizing light is apple green birefringence. If you've ever seen it, it doesn't look like the green apple you would actually want to eat. It's kind of got this eerie glow. But it does require some expertise. And we see many patients where our pathologists review specimens that were said to be negative for amyloid, and actually they do have it. And we look for it not just in the bone marrow, but what's often seen is just little collections of it in the walls of the small blood vessels in the bone marrow. We need to demonstrate amyloid tissue deposition. So if we don't see it inside the bone marrow, which is an easy place to go, then we start biopsying other organs. And the most common place besides the bone marrow is the abdominal fat pad. In one study, if you did both a bone marrow biopsy and a fat pad biopsy, you can detect amyloid deposition in about 80 to 85% of patients. And for some of our patients, we kind of do a 2-for-1. We'll send them to interventional radiology and ask them to do a bone marrow biopsy and an abdominal fat pad biopsy at the same time. We get the results very quickly, much faster than sending the patients to a surgery clinic and waiting for them to get them on the schedule to take the little piece of abdominal fat. But if those tests are negative, we start going after tissues that might be involved. And so that could include kidney biopsies, endomyocardial biopsies, liver biopsies, and so on. And again, once we have it, we still don't know what we're dealing with. We know we have amyloid. We need to know, is it really light chain related, or is it TTR? Is it one of the other 42 types of amyloid? And so we need to do some way of doing that. And the most common test and the gold standard now is mass spectroscopy or mass spectrometry. This is done by Mayo Clinic for us. We send them a sample of the tissue block. They do laser microdissection and then do mass spec and get the chemical protein structure of the amyloid. And they'll send us back a report that says this patient has lambda light chain amyloid, or this patient has hereditary amyloid, and here's the mutation that they have, as well as all the others. It takes 2 weeks to 3 weeks to get that result. But hopefully the more centers will start to do that in the future. So if you're seeing a patient and trying to figure out, hey, I paid attention, there's no coffee or kolaches, but I stayed awake for at least the first 10 minutes of the talk. What exactly should I order? And so we've been working with Dr. Zaidman, Dr. Jacobs in laboratory medicine, and this test should be available in Epic in the coming weeks or months. And you'll be available to order that on inpatients and outpatients. It'll be called an amyloid screening panel. And again, it's designed for an initial screen for patients who have a clinical presentation that is consistent with amyloidosis. It is not exhaustive. It is not every test that I would do, but it's a good way to start out saying, do I see some abnormalities that make me suspicious enough to refer the patient? And so that's looking for a serum immunotyping or immunofixation. So in the serum, do we see a clonal IG heavy chain or light chain, or IgG kappa or just kappa light chains? Serum-free light chain test, looking for elevations of the kappa or lambda chains or an elevated ratio or a combination of those. And then a urinalysis with urine protein creatinine ratio. And this will help us not just looking for patients who might have light chain amyloid, but it also helps with other proteinurias that might be picked up. One of the things to remember, I think I tell everybody this, the urine dip does not pick up free light chains. So you can have a patient with 500 milligrams per deciliter of free light chains, but if they're not spilling albumin and you do a urine dip, it will be negative. So the urine protein creatinine ratio allows us not just to see albumin and other proteins, it allows us to see free light chains. But even these tests have some pitfalls, and I think many times I see patients who have been seen by some oncologists outside where the diagnosis has been dismissed because they have negative testing and it needs to be evaluated. When we look at patients, we always talk about, do they have a clonal protein we could see? And about 5% of our amyloid patients with light chain amyloid have a negative serum immunofixation and a urine immunofixation on 24-hour protein. So we can't detect, at least at our current level of detection, a clonal protein. About 10% of patients have a normal free light chain ratio. So they may have an elevation of kappa that's just slightly elevated, and that's a representation of their clonal plasma cells, but it's not so high that the ratio becomes abnormal. And in some patients, you can see very minimal elevations. About 20% of patients have what's called low free light chain amyloid, where their light chain elevations are so low that they actually aren't able to enter clinical trials because they don't meet criteria for amyloid according to clinical trials. So what I would say is, and Dr. Mitchell says, am I sending you too many emails about light chain tests? And the answer is no. If you ever do light chain tests or this type of testing and you're not sure how to evaluate it, or you're trying to decide, these tests are all negative, but I'm really suspicious, should I refer the patient? The answer is yes. I think if we're screening patients appropriately for amyloidosis, we should be seeing some patients who actually don't have amyloidosis. There's a staging system Dr. Vid showed last week, the Mayo staging system. The staging system we use for amyloidosis looks at basically two cardiac biomarkers, the proBNP and troponin T. And about 40% of patients have stage 3 disease. There's 3 stages. Stage 3 patients have both elevations of proBNP and troponin T. And this study from the group in the United Kingdom looked at that group of patients who already have stage 3 disease and tried to say, well, are some of them going to do better than others, and who's going to do exceptionally poorly? And so they broke that down into patients who had proBNPs of greater than 8,500, as well as systolic blood pressure of less than 100. And if you look at that curve, that looks really terrible. Patients who have 2 high-risk features, their median survival is only 3 months. And even patients who have no risk factors, the median survival is only 2 years. It may be that we're getting better with some of the newer therapies, but it's not clear yet that we've gotten where we need to be. So how do we treat these patients? Again, we're dealing with a problem of a clonal plasma cell disorder being driven by plasma cells. Ravi, when he gave the talk, talked about dealing with a sink that's full of water, meaning amyloid, it's not draining. And at the same time, the faucet's turned on, so more amyloid's pouring in. So what we can do with chemotherapy is kill the plasma cell, turn off the faucet so we prevent any new deposition of amyloid in the tissues. But right now, we don't have any drugs that help open up that drain and start removing the amyloid from the tissues once it's deposited. So our goals with treating these patients is to suppress the amyloidogenic clone with chemotherapy. We hope to prevent, at least at a minimum, worsening organ dysfunction. But what we can see, depending on how well the patients respond to their systemic chemotherapy, some improvement in organ function. So the body can remove some of the amyloid deposits. This is very poorly understood, but we do see some patients have improvement in organ function, and patients who are New York Heart Association class 3 or 4 who become class 1 and go on to normal activities. One of my patients we interviewed for one of our amyloid symposium, he couldn't sit up for the entire visit with me. He kept dropping his blood pressures and basically had to lay down because he couldn't sit upright even for 5 minutes because of his orthostatic hypotension. And is now back to his normal life, running his business. So our goal is to hematologically attain a complete response or a very good partial response, meaning that we drop the protein levels by 90% or more, or make it to the point where they're undetectable. And this is some data showing that the better you can control the disease hematologically, the better you can see organ response. So on the left, this is a group of over 1,000 patients in Italy. You can see the patients that got a partial response, meaning a 50% drop in their light chain protein, only had about a 20% improvement in their organ function. If you look at patients who attained a complete response, it's about 50%. And if you get patients to a minimal residual disease state, where on flow cytometry, you're not able to detect 1 in 10 to the 5th or 1 in 10 to the 6th abnormal plasma cells, you can see over 80% of those patients have improvement in their organ function. And on the right side of the slide, a similar sort of a picture of that you can see much higher response rates, both in the kidney and in the heart, if you get these patients to MRD negativity. So this is a slide, if you can memorize this slide, you know everything you need to know about how to deal with what's our current treatment paradigm. And that is, when we see a patient, how do we treat them? The first decision is, are they a candidate for stem cell transplant? If they are, we give them some initial chemotherapy and then proceed to a stem cell transplant. We have such good chemotherapy that some of our patients with just initial chemotherapy will go into complete remissions and may not need a transplant. But our goal is to take these patients to transplant and try and get them into a very good partial response or complete response. And I'll show this very briefly, how we've done over time. This looks at over 1,500 transplants reported to the bone marrow transplant registry going from 1995 to 2012. On the right, which is the overall survival, the gray is the most recent time period, and you can see the 5-year survival is about 80%. If you look at the initial group of patients we transplanted in the 90s, and I'm old enough that I was doing it back then, the overall survival at 5 years was only in the 50% range. And on the left, the transplant-related mortality, about 20% of our patients would die because we didn't know how to select patients. We also didn't have any other options for them. But we now have transplant-related mortalities that are very similar to what we see with patients with multiple myeloma. And the big problem with patients with amyloidosis is they have organ dysfunction already related to the amyloid deposition. So trying to put them through an intense therapy with large amounts of IV fluids, if they get hypotensive, they have to get more IV fluids. They have borderline renal function. They may have coagulopathies. And this shows that the patients who have cardiac involvement do significantly worse after transplant. They still can have improvements, but the median survival in patients with cardiac disease who get a transplant is only about 4 years and is double that without cardiac involvement. I won't go through the transplant criteria. They're there in the slides. If you're interested, there's actually 3 pages of criteria. But basically, the patients need to be able to handle a stem cell transplant and then also not have enough cardiac or other organ dysfunction that we're going to run into problems. And so most of our patients who go through a transplant for amyloidosis are consulted by either the nephrology or cardiology teams or both. As I mentioned, the patients go through a transplant. If we get an adequate response, they're observed. We don't do maintenance therapy as we do with patients who have multiple myeloma. For the patients who are not candidates for transplant, we now have an approved drug. There's one approved drug for amyloidosis. that came out of this trial, the Andromeda trial, and this has changed the standard of care. It was just approved 2 years ago. This is a prospective randomized trial of a standard 3-drug regimen, a proteasome inhibitor, bortezomib, dexamethasone, and cyclophosphamide, with the addition of daratumumab, which is a CD38 antibody. And this looked at a number of endpoints, hematologic response, as well as progression-free survival. And again, I won't go into too many details of this, but all of the parameters show basically a doubling of outcomes improvement in terms of how deep we can get remissions in these patients who had the addition of daratumumab, as well as organ response. So the cardiac response was 42% versus 22% at 6 months and 54% versus 27%. One thing I'll say about getting patients into remission, we can get hematologic remissions in 1 or 2 months. In fact, the median time to a very good partial response on the patients getting daratumumab was just 17 days. But it takes a long time for the organs to get better, and it could be 6 to 12 months or more before we start to see cardiac and renal improvement. And in half of our patients, we don't see that. So even though we get patients into remission, if they're in that group of patients with a median survival of 3 months because of significant cardiomyopathy, we may not be able to stop the clock on that. And that's why getting patients diagnosed earlier is very important. This just shows the progression-free survival, showing that the patients getting daratumumab did better than the patients who just got the 3-drug regimen. And unfortunately, this is a disease we can't cure. Patients over time can relapse or have progression, or if we don't see an adequate response to therapy, we very quickly have to switch things around. We know that until we have the patients in remission, they're getting more amyloid deposition in their organs and more organ dysfunction. So we are very aggressive. If patients after 2 or 4 cycles don't meet certain goals, we switch chemotherapies. What do we do next? Well, that's a great question. We don't know what the right 2nd line or 3rd line drug is, because the drugs we have not been tested very much in amyloidosis. There are very few clinical trials. There are no phase 3 trials of 2nd or 3rd line therapy. But basically all of these drugs that we use for multiple myeloma can be used in one way, and they're being tested in various trials. And I'm going to end up, because I don't want to take all of Josh's time away, of can we do something about that other part? We've turned off the faucet. Can we empty the sink now? I keep using Dr. Vidge's criteria. I feel like a plumber. Can we open the drain? And so there are actually 2 drugs in clinical trials, birtamimab and KAL-101, that are actually directed at the amyloid fibrils. Both seem to have activity at actually removing the fibrils even without chemotherapy and getting organ responses. And so we have 2 clinical trials of KAL-101 in patients with newly diagnosed multiple myeloma. They get that 4-drug chemotherapy regimen, and then they're randomized to KAL-101 versus placebo. So we're hoping that we can start to improve outcomes by getting organs to improve quickly. As far as investigational therapies, as I mentioned at the bottom, the antifibril therapies, KAL-101 and birtamimab. We're starting to do some studies of the immune therapies. These are targeted mostly at BCMA, either CAR T cells or bispecific T cell engagers. For those of you that know the agents, their main side effect is cytokine release syndrome. So fevers, hypotension, and respiratory distress, and doing that in someone who's got borderline cardiac function is rather difficult. And we also have ZND5, which is a BCL2 inhibitor available for trials. So I'm going to turn it over to Josh. In summary, if you're not thinking about amyloid, you're not going to make that amyloid diagnosis. And so if it gets there, it should be higher on your list, hopefully today, than it used to be for these patients. But feel free to reach out to us if you have any questions about these tests. I'm going to turn it over to Josh. Thanks for your attention.
That was an excellent overview, Keith. So thanks so much for leading us off. And I'm going to cover some of the same things as far as the diagnostic barriers, because I think that's the most important thing that we could possibly cover. Because the earlier we diagnose it, then this treatment, all the other things falls in line. But then we'll also focus some more on the TTR side of amyloid that we haven't covered quite yet. Most of this will be focused on cardiology because I am a cardiologist, but there's obviously transitions with other parts of internal medicine because amyloid is a systemic disease. And so certainly with neuropathy, especially, we have treatment specific for neuropathy, but it's so important for our GI specialists, our renal specialists, everyone to be in tune with our amyloid diagnosis so that we can find it earlier. And case in point, Dr. Elizabeth Blaney, who's our GI specialist in the Amyloid Center of Excellence, just messaged me yesterday about a really sad case that she just saw where the diagnosis was delayed. And she's sent me a couple of cases recently where she's picked up on the amyloid from the GI specialist. So it's really important for everyone to be in tune for the possibility of amyloid. So here's the objectives. In essence, we want to understand the risk factors for amyloid. When should we be thinking about amyloid? What's the likelihood that they have it? And then let's apply some expert consensus recommendations to the workup. And then let's also understand the treatment modalities that are available to us. So for the pathophysiology of ATTR-CM, and so the amyloid is named based on the molecule or protein that is causing the amyloid. The first A just stands for amyloid. The TTR in this case stands for transthyretin. Transthyretin derives its name because it's a transporter of thyroxine and retinol. So that's what it does normally in our body. So it's a normal protein. It's produced by the liver. It normally exists in tetramers. As a tetramer, it's nice and safe. It doesn't do any damage. But unfortunately, sometimes it can dissociate into dimers or monomers. And this is when we start to get into problems, and those monomers can aggregate and form fibrils. When we have hereditary causes of TTR amyloidosis, those genetic abnormalities are generally going to either one, cause it more likely to aggregate, or number two, more likely cause it to deposit into amyloid fibrils, or potentially to dissociate. Ultimately, once we have the amyloid deposition in the tissue, in this case, we were highlighting the heart, then that's when we start to see the pathology of the disease. TTR, just like AL, is a very systemic disease, but I wanted to highlight some discrepancies, not because anyone in this room, including myself or Dr. Goldstein, can clearly tell the difference between an AL amyloid patient or a TTR patient in front of us, but there are some differences. And so sometimes if we're used to seeing TTR amyloid and we anchor on that diagnosis, we'll miss AL or vice versa. These are some of the common symptom complaints in TTR. A lot of them mirror AL. I will highlight that TTR amyloid is more likely to cause musculoskeletal complaints. Those carpal tunnel syndrome issues can happen as much as 10 years, or even in a case I'll show you in a minute, 20 years before they develop cardiac issues. And so they're a real clue. Now, of course, this is tough because we've all seen lots of people with hip or knee replacements and they haven't all had amyloid. But when we start to see these musculoskeletal complaints, in addition to other issues like cardiomyopathy, arrhythmia, neurologic issues, or GI issues, it certainly should make us start to think of amyloid. Conversely, an AL patient, here we see the bruising or ecchymosis around the eyes, as well as the larger tongue. These are symptoms that are almost always from AL. Now, again, nothing is perfect in amyloid. TTR amyloid only had a treatment that was FDA approved a few years ago. So we're all still learning, and there's certainly a case report that I could find for macroglossia from a TTR amyloid. But if I see a large tongue, it's almost always going to be AL. And certainly the most important thing is to rule out AL. As Dr. Goldstein showed you, the prognosis for these patients are really poor, especially when they're underdiagnosed. So we want to make sure we diagnose AL or rule it out before we start going down other pathways. And then from a more cardiac standpoint, we all think about the thicker heart. This is a TTR amyloid patient, a much more classic appearance. You might even say it has that speckled appearance, but really we see that thickening both of the septum, which is the top part of the image, and then the posterior wall. But especially with AL, we can see pretty normally thick walls. This particular heart had a septal thickness that really was upper normal. Maybe you could say mildly enlarged, but otherwise might have gone unnoticed. The sparing pattern, some of you may be aware of the apical sparing pattern, which I'll talk on later, wasn't really present. But when he did have a restrictive cardiomyopathy, he was on our firm service, so we did do an MRI, and the MRI was the most positive I've ever seen. And what is positive here, you can see the outline of the heart in white. There should not be any white, and so it's all white. And so there's all late gadolinium enhancement on this slide. And really could have easily been missed. This, fortunately, was the initial presentation. He presented with an EF of 45% in heart failure, but we were able to make the diagnosis at the start. And he's doing very well. So if we find it on time and treat it, they do very well. And he's been my patient now for a few years, but it's still a good example. So for TTR amyloid, there is, depending on the genetic mutation or whether you have wild type, and I'll go over what that means in a second, some differences in deposition of tissue. Some genetic abnormalities are more likely to deposit in the nerves. Some are more likely to deposit in the heart. We don't know why yet. We're still learning. But again, no rules are sacred. So historically, V122I, also known as V142I, depending on whether you count the first 20-unit sequence at the start, has historically been thought to only affect the heart. And here in this article from 2020, it's all cardiac, but we are seeing more and more cohorts of people with nerve involvement too. So there can be some differences here, but these are rules of thumb. Wild type ATTR, which means I cannot find any genetic abnormality if I do a genetic testing, generally affects the heart much more than the nerves. And it has a very strong male predominance for unclear reasons. We don't know yet why people are more likely to get wild type ATTR. Why does that protein misfold in some patients, but not others? There is earlier work looking at that. As I mentioned earlier, transthyretin is the transporter for thyroxine as well as retinol. And there is work that shows that people who have decreased levels of retinol binding protein may be more likely to have amyloid. And so there's still work in these other types of proteins that the transthyroxine is interacting with, maybe that cause the problems. Wild type usually has onset over 60, average age is around 70. Some of the variants, such as the Val122ILE, has a similar age onset around that same age. Others can happen much earlier. The T60A mutation, which is the Irish gene, but also felt to be the Appalachian genetic abnormality. I have patients that have onset of symptoms at 40. Sometimes we can have onset even earlier. And V30M is the most common worldwide, which is usually neuropathy predominant, but also can have cardiac symptoms. So how common is amyloid? Well, we used to think it was rare. We certainly are diagnosing it more and more. Our patient population at WashU continues to expand greatly as we pick it up more often. But in series of patients, some with heart failure, so in a couple of HFpEF series, people who died of heart failure, had no known amyloid at the time of death, but did have diastolic heart failure. We can see deposits of amyloid in their tissue in around 15%. We don't 100% know that that is the cause of everything, but certainly it went undiagnosed in a large portion. We know that it's age predominant again, so that we see a lot more after the age of 80 and even after the age of 95. In aortic stenosis, there's been series that have shown it again around 10%. And then also in carpal tunnel surgery in a series of 98 patients going through carpal tunnel surgery. Most of them were bilateral, but some were not bilateral. 10% had amyloid deposits in their carpal tunnel. Now, again, I said that exists usually 10 years before the heart, but still surprisingly, 2 had cardiac involvement and 2 genetic abnormalities were picked up in that screening. And so there's certainly a push now more to do Congo red staining more routinely in carpal tunnel surgery. So one patient I saw that just highlights the issues is a 76-year-old African-American lady. She's had repeated hospitalizations over the last 5 years. She had no coronary disease. She had carpal tunnel syndrome 20 years ago and also now suffers from severe neuropathy. And at the time I see her, she's had severe GI complaints as well. Her oral intake has plummeted. She has dysphagia. She has diarrhea. And then she also has been noted to have severe hypertrophy on echo without significant hypertension. She gets a PYP scan in an outside hospital. But unfortunately, with the delays in diagnosis, she goes on hospice just a month or 2 later. And we don't want this to happen. And certainly in this particular case, there are a lot of clues to the diagnosis that got missed. But one of the biggest issues that I also see in amyloid is that we rest on any one clue. So, oh, they don't have, this person's hypertensive, so they can't have amyloid. Or this person doesn't have X, Y, or Z, and so they can't have amyloid. And so we don't want to anchor on any one thing. Certainly this patient should have screamed amyloid, but sometimes we miss it because we're not focused on it. We don't do a full review of systems. We're focused on the heart. We don't ask about diarrhea. And unless you ask those questions, you're going to miss them. Fortunately, we know that amyloid is getting much better. We're getting much better at diagnosis. This is from a Danish cohort. We see the increase in diagnosis of amyloid from the 1990s to the 2010s. And this is before tafamidis approval, which has really made a huge improvements in amyloid diagnosis, both because we have treatments for TTR, and we also have Pfizer, who makes a lot of money off treatments for TTR, who is trying to educate everybody on diagnosis. So that's also helping. We also know, looking at the Danish cohort, that if we diagnose it earlier, or as we diagnose it more often, we're seeing better survival. So this is kind of laid out where the more recently you're diagnosed, we see improvements in survival. We also know that a lot of this diagnosis from the cardiac side is wild type. So we were better before about the genetic cohorts because we've screened family members for genetic disease. But the blue in this graph is the increase in wild type diagnosis, while the red is much more steady for variant cases. There's still work to do. A couple years ago, we did a study with Dr. Schiffer and Dr. Kurak, who's now at UT Southwestern, looking at all the patients in our system that had echocardiographic findings of potential amyloid. So the echo reader said, I'm worried about possible amyloid, using one word or another. Of those 451 patients, only a quarter of them were evaluated completely for amyloid based on expert consensus recommendations. Some might have had one test, but not another. Some may have had a mild abnormality that wasn't followed up. A half went under some evaluation, but not a complete, and 50% of the patients don't have any record of any evaluation in our system. There are some predictors of being less likely to be evaluated. One was not being Caucasian, which is surprising because in our population, we probably see increased risk in African Americans, especially with the VAL122ILE mutation, which is found in 3 to 4% of African Americans in the US. And then there are comorbidities such as hypertension, diabetes, or CAD. Unfortunately, none of those rule out amyloid, and a third of our patients in this cohort were hypertensive at the time of their echo. And so if we just say, oh, they're not hypotensive, so they can't have amyloid, then that also leads to misdiagnoses. There was no difference among high-risk echocardiographic findings across the cohort. So in the end, we are missing people. I do think we've gotten better since we did this study, just again with the onset of tafamidis and with better education, but there's still work to do, highlighted by Dr. Blaney talking to me yesterday about a case that had been missed for a few years. So who should we screen? I talked earlier that sometimes we anchor on one or the other, but there's differences. So this particular expert statement that came out in 2019 by Dr. Whittalis, who's an expert in the field, he's very knowledgeable, and his team, they said that people at higher risk for ATTR cardiomyopathy, we should focus on males over 65, females over 70, with a wall thickness of 1.4 centimeters. And certainly those patients are at higher risk. But if I only use that to prompt an amyloid evaluation, then in that cohort of patients at WashU, I'd have missed 52% of them. 52% of them would not have qualified for screening in this particular cohort. Most of those are AL, and AL were much more likely to see normal thickness walls, but we also would have missed TTR patients. More recently, a European expert consensus statement came out, and they lowered the bar a little bit to a wall thickness of 1.2 centimeter, and then any one of numerous signs. And this does a much better job. It would have only missed 3 patients, and you have to balance it, because if I screen absolutely everybody, that probably is overkill, but certainly I want to make sure that my threshold is appropriate, especially because screening nowadays is a lab test or lab tests and a non-invasive imaging test. And so we're not causing harm, and we should have, as Dr. Goldstein said, negative testing, or we're not doing enough. The other thing I see wrong, and even with Pfizer, who's trying to improve diagnosis of amyloid, they have an acronym called HIDDEN, but it tries to capture all of the things. And what I really like about this ESC expert consensus statement is that it says any one of the following. So it doesn't say 3 of them or 5 of them, any one of these things with a concern for wall thickness. So again, pitfalls in diagnosis, we're taught kind of in medical school that we're focused on left ventricular hypertrophy. But 35% of AL patients have normal wall thickness. We think sometimes of restrictive cardiomyopathy. So in this case, the amyloid has invaded the wall. It's made it thick. It doesn't move very well. And then that pressure builds. The atria, or the initial entering chamber of the heart, starts to expand. And that does certainly happen in amyloid. But in the registry, an international registry, only 18 patients were reported as meeting that criterion. If I look just for low blood pressure, As I mentioned before, over 30% of patients diagnosed with cardiac amyloid in that WashU series were actually hypertensive over 130 over 80 on their at the time of their echo. And then we also think of low voltage QRS, which is again helpful, but 25 to 40% of TTR cardiomyopathy patients have low voltage, and actually 25% in the registry had high voltage on their EKG. So we don't want to anchor. These are clues, these are risk factors, but they aren't diagnostic tools, and so that's why the screening tests are important. More recently, the apical sparing pattern has been out there. This was a fairly small cohort of about 50 amyloid patients, and then 15 aortic stenosis controls and 15 hypertrophic cardiomyopathy controls. And patients with amyloid were much more likely to have this apical sparing pattern that you see at the top of your screen, where the middle part of the heart, or the apex of the heart, is more red, which means that the numbers are more negative. It's working better by this measurement than the base of the heart. And this study was 93% sensitive and 82% specific for that pattern. But unfortunately, if we try to apply the same pattern to a more unselected patient population, it's not as good. These are 4 representative samples of things that by the calculator were apical sparing. And you can all decide which ones you think have amyloid of these apical sparing pattern. And I will say that only D had amyloid, all the rest did not. So it's not perfect. And conversely, patients that have amyloid don't always have apical sparing, like the one I showed you earlier. Our study did find, as others have too, that the EF to strain ratio can be very helpful. So the strain drops first in amyloid before the ejection fraction. And so when we have a strain drop out of proportion to an EF drop, and that ratio goes over 4.1, that's more likely to be amyloid. So here's the AL amyloid patient I showed you earlier, whose strain had dropped out of proportion. Normally it's a 3-to-1 ratio. So for an EF, I'd expect a strain of negative 15%. For an EF of 45%, his was negative 7. So again, we want to make sure and use these clues, but we don't want to anchor on any one of them. So if we have a heightened clinical suspicion for any number of reasons, then at that point in time, we want to start thinking of screening. It's always important to do some diagnostic counseling for the amyloid patient. And it's a balance, right? Because at the time of screening, we don't know if they have amyloid. We certainly don't want them to start Googling how poor of a prognosis AL amyloid has, but we also want to let them know that it's important to diagnose it if they have it. And it can require a few different tests, as you saw on Keith's slide, Dr. Goldstein's slide, on all the things that may have to happen. And then we also usually in the cardiac clinic, in our clinic, we will also go ahead and do the genetic test for variants in patients that might have TTR amyloid. So we do the test that Dr. Goldstein highlighted that should soon be a part of the screening tools in EPIC. If those tests are abnormal, then they generally need a biopsy. You need tissue diagnosis, and that usually means I refer to Dr. Goldstein for further workup. They'll start with a bone marrow and fat pad. If that's negative and you're seeing me, then there's some concern for cardiac amyloid. And there are a significant amount of people who have negative fat pad and bone marrow biopsies, but will have a positive endomyocardial biopsy. So if the initial testing is inconclusive, they'll go to heart biopsy. If they have normal screening for AL, no monoclonal proteins, then they'll get a PYP image. And if that is negative, grade 0, then you're basically done. If it is grade 1, it is still more likely amyloid than not. So they will need a tissue diagnosis with a biopsy. And if it is grade 2 or higher, it's positive, and we just need to know if it's genetic or not. We certainly want to know if it's genetic because that informs the risk of their relatives. They have a 50% chance since this is an autosomal dominant disease. Here, just to kind of highlight the importance of following this, we have a 70-year-old Caucasian male, came in with a plasma dyscrasia about a year ago, but has more recently progressed to multiple myeloma. On his screening echocardiograms, he's noted to have thickening of his heart. He has what's called the 555 sign, which just is a sign of restrictive heart disease. It's not moving very much. And then he has apical sparing pattern. So it's felt he has multiple myeloma. He has signs of cardiac amyloid. So really the thought now is that he has AL amyloid, and he starts treatment for his multiple myeloma / AL amyloid. He's treated with a good regimen, goes through stem cell transplant, and is on single agent daratumumab, but he doesn't seem to be improving the way we would expect based on his response to therapy and his cardiac prognosis or progress. And so the thought is, well, maybe we need to see exactly what's going on with the heart. And so he does undergo an endomyocardial biopsy, and he is found to have amyloid on the biopsy, so confirming the fact that he has amyloid, but he has TTR amyloid and multiple myeloma. And so again, anytime we're worried about AL amyloid, we have to have a tissue diagnosis. And in a series of 350 patients with AL amyloid, about 10% had a genetic mutation and that could cause amyloid. So you can have a TTR mutation and you can still have AL amyloid. So there's crossover there. And in a series of TTR patients, a large portion have MGUS, monoclonal gammopathy of unknown significance or uncertain significance, much higher than the background prevalence. So the reason we have our diagnostic modalities is we have to rule out AL. If we have AL, we have to have a tissue diagnosis. And then once we exclude AL, then we can use PYP for diagnosis. Here's an overview of PYP. Essentially, pyrophosphate was designed or came out to target bone, but it was found to also bind to amyloid fibrils in the heart. Grade 0, we don't see any uptake in the heart. Grade 1, we see uptake, but not as much as bone. Grade 2, we see uptake the same as bone, and 3 is more than bone. In a series of patients that led the way in making pyrophosphate as a diagnostic tool for amyloid, you can look at patients in this study had a few different tracers, but the ones who got pyrophosphate are listed here. And you can see that for grade 0, only one patient had TTR amyloid. So PYP is only used for TTR amyloid. We talked before that if you're concerned for AL, you need a tissue diagnosis. And so if you got a grade 0 PYP scan and did not rule out AL, you could have missed a significant amount of cases. When we look at grade 1, there are still centers, and I still review papers that talk about grade 1 being a negative test, but you can look at this cohort of patients where grade 1, almost all of those patients that were referred to an amyloid center, so there was a high pretest probability, almost all of them still had amyloid. So if you have grade 1 tests, you still deserve further evaluation. Where grade 2 is almost always positive. In this particular case, one patient didn't have amyloid. The authors of this study said that they had a plasma cell dyscrasia and characteristic echo findings, so they think the biopsy might have been a false negative, the biopsy was a false negative. That's obviously an opinion, but overall grade 2 or grade 3 increased the risk of amyloid. We staged the disease based on biomarkers. There was a recent paper that looked at PYP scan even on grade 3 over grade 2 didn't actually signify a worse prognosis. So biomarkers have been shown to be the best way to stage it currently. And we generally use NT-pro and eGFR. I'll briefly make a comment on MRI. MRI is a useful tool if you're worried about pretest probability and trying to decide whether to biopsy a patient. And this ESC guideline, really MRI came out if we had a grade 0 test and we weren't sure if the grade 0 was a real test, and we're like, what do we do after that? But again, I find it most useful for that. Now, I do have a working collaboration with Dr. Lanza over at the Cortex to see, can we use MRI to better diagnose amyloid? And certainly with new parametric mapping, we have much better tests to find the amyloid than before. When we just relied on contrast, it was not a good enough test. But with the newer testing, we do see a lot of different changes that can happen. And so we do have ongoing work seeing how can we best diagnose amyloid with MRI or other non-invasive tools. So a few words on treatment. Treatment can either focus on the TTR production, so shutting down production. Historically, that was with a liver transplant. No, you don't produce the mutant gene anymore. Now we have genetic silencers that target the RNA molecule, such as patisiran, which is a every 3-week IV infusion, or anotirsen, which is a once-a-month injection. Now we also have Amvuttra or vutrisiran, which is an every 3-month injection. That's the same as patisiran. So we're just continuing to have more options from this level. They do shut down TTR production by about 80%. Because they shut down TTR production by 80%, they really do have phenomenal effects. The one downside is that, as I mentioned, transthyroxine carries vitamin A. So we have to make sure that people are on vitamin A supplementation if we're shutting down their TTR production. If we look at stabilization of that tetramer, that's where tafamidis is out. Tafamidis is actually the only FDA approved currently for cardiomyopathy. Patisiran and anotirsen are for neuropathy, but they have good cardiac effects. So everyone that has a cardiomyopathy will be prescribed tafamidis, whether they're wild type or whether they're hereditary. And then on the bottom, we have ongoing research with including PRX004. So Dr. Goldstein mentioned we don't have anything yet that clears the amyloid fibrils out of the body, but this is an antibody that targets the amyloid fibrils. that's under study for TTR amyloid. If we look at the studies in brief, tafamidis had a significant improvement, a 30% improvement in mortality in a disease that has a terrible prognosis. The number needed to treat to prevent one death was only 7.5. And we also saw significant improvement in quality of life as soon as we measured it at 6 months. So even at 6 months, we see improvement in the 6-minute walk test and the Kansas City questionnaire. Now, I always counsel patients that tafamidis does not improve the disease, it slows progression, but there are some patients who do feel better after starting it, and we do see some improvement in biomarkers, so I don't think it's only placebo effect, but I would never counsel patients to expect that. It's really slowing progression. Looking at patisiran, which is that RNA interference molecule that comes out for neuropathy, this is a remarkable drug that not only slows progression, but shows improvement. So in the NIS, which looks for basically severity of disease, and higher numbers are worse, so going up is bad. Placebo patients continue to go up, and patisiran patients try to go down. And we also know that and this is just the p-value, which is amazing off of 225 patients about how good of a drug it did by shutting down TTR production for neuropathy. And then for the Apollo sub-study, which means that they were treated for the neuropathy, but they also had a cardiomyopathy, we saw improvement in multiple models or multiple parameters with their heart. And so recently, the Apollo B trial has been conducted, which WashU is part. And so far, we've released early results that show improvement in 6-minute walk test and NT-proBNP, but don't yet have the survival data. It is not yet FDA approved for cardiomyopathy. So here are current treatments. I X'd out tafamidis because that's available in Europe for polyneuropathy, but not the US. Vutrisiran is the newer form of patisiran that's an every 3-month injection, and there's ongoing clinical trials. Importantly, if you have a patient with amyloid, WashU does have access to patisiran for cardiomyopathy under an early access protocol that's free to the patients under a research protocol. And so we're always trying to find new treatments to make available for them. So again, suspicion for amyloid. I think I've hammered this home during the talk. We shouldn't anchor on any one thing. Let's focus on all of the different parameters that put you at risk for amyloid. Always make sure to test for AL. You have to rule out AL first. And if the AL labs are abnormal, then you refer it to Dr. Goldstein and his team, and it needs a tissue diagnosis. If they're normal, PYP scan, and MRI can be used to help with our pretest probability. And then just to hit that home again, grade 1 PYP scan is still most likely cardiac amyloid, so don't consider that a negative test. With that, I'll finish with a slide of our Amyloid Center of Excellence. So it's only possible with a group of people from a multidisciplinary background. We have excellent providers from many different specialties, and it's a pleasure to work with all of these. And I also want to give a word of thanks to our clinical and research support team on the cardiology side who help us with our clinical trials. And with that, thank you. And here are your QR codes.
Great presentation, so thank you so much. Everyone's getting their QR code.
Fred?
Yeah, so another, just talking about the screening lab, or that screening panel, other like like there's a different test that initial one.
Yeah, the serum free light chain test. So the serum free light, immunotyping. So immunotyping is another way of doing immunofixation. So it's a way to more sensitively look specifically for the type. So serum protein electrophoresis will let us know if there's a spike in the protein smear, but it doesn't tell us what the subtype is. So we could see that there's a spike in the gamma region, but it doesn't tell us if it's kappa or lambda, if it's IgA or IgG. So immunotyping and immunofixations are the way to do it. And immunotyping is, or immunosubtraction is done with capillary tubes. And I could give you a 30-minute lecture on that if you want. But so that's just the current version. Depending on where the lab is, for example, if you do the sample here, they'll do immunotyping and probably immunofixation as well if the immunotyping is negative.
And then most common phenotypes are abnormal, like labs, like
Yeah.
How do you interpret that?
Yeah, so Dr. Fitz showed a nice slide. It was from that iStop myeloma study in Iceland that now gives us an idea of how renal function impacts the light chain. So we have better idea, but I think, and I see a few patients a year who don't have amyloid who are referred strictly for abnormal light chains. The light chains are also affected by other things. If you have a recent infection, if you have autoimmune disorders, the light chains can be elevated as well. Typically, the ratio will be normal in those cases. So when someone who's got CKD, it just makes the diagnosis even harder because you don't know if those are elevated because they have amyloid or because they have kidney dysfunction or not. So those are the cases that are difficult, and those are ones to reach out to me or one of my colleagues and say, hey, what do you think of these labs? Should we do some more detailed testing?
Great, thank you all.
Sure.